Yeah, welcome everybody. I would like to add a few notes which might have been told by other candidates for past exam. It's technical issues regarding the rapid reporting and long cases. Just for the long cases, you're going to find yourself typing in a noisy environment. So just be prepared for that because it's a little bit annoying. It might be distracting, but just be prepared for that because all the candidates will be typing at the same time. And don't be astonished if you see candidates typing as soon as the invigilator tells them to start answering the questions. This could be maybe some candidates have prepared management for the cases, even before starting to see the cases and the history. So just don't be panicked for that and take your time. I advise you to bring earplugs for that. Also regarding the Viva, there is no headset in the Viva rooms. So I advise you also to bring a headset because sometimes you might not hear the examiner well. So just to avoid anything that might cause any interruption for your Viva. I think you can request that maybe during the application, but you can even email Sharon or one of the team about this, but just prepare your headset and earplugs to avoid unnecessary annoyance and missing important findings in your exam. One more thing regarding the rapid reporting, the stress of rapid reporting the exam is less than that of lung cases because you first start with the lung cases because in the lung cases, you do not know what cases you may get. But in the rapids, you have a checklist and you are almost familiar with all the pathologies that may appear on rapid reporting. So the stress is less, just stick to your checklist. Rapid reporting is that component of the exam with has precious marks. I mean, by this, the mark you get in rapid reporting are easy to get and also easy to lose. If you score like 29, I mean, if you got 29 correct answers, you may get 7. Okay, and if you get them all correct, you get 8. So the 1 mark can be acquired from answering one question correctly. So this 1 mark cannot be easily got in Viva, cannot be easily got in lung cases. So rapid reporting is really very important compared to exam. The lung cases are difficult to fail, but it's also difficult to get a very high mark in lungs. But in case that you give a diagnosis in all cases, you may get 6. You may do well or better in some cases that which compensate for other cases. So don't worry if you do not give full answers for all cases. So just try to attempt all cases. Don't spend too much time on one case. So getting an 8 in one case and failing other case or not attempting it. Regarding the Viva, it's unpredictable. The different candidates will get different cases. different situations. So just try to keep strong or to be strong until the end of the Viva. You might do well in one Viva and bad in the other Viva. Don't let answering cases bad affect your performance in the next case. So just proceed and you'll be fine, inshallah. So let's start the session with candidates. When are you with us?
Dr. Nuran, you are the first one.
Yeah, I am here. Hi, Dr. Yousif.
Hi, Dr. Nuran.
Dr. Yousif, do you want us to keep the time or you'll manage yourself?
Yeah, it's fine. It's fine. Yeah, keep a time.
15 minutes?
Okay. Yeah, it's fine.
Okay, thank you.
So this is your first case, Dr. Nuran.
Okay, sir. Well, I've been provided with the frontal chest X-ray of an adult patient. No any history given to me. So I can see there is, I'm looking to the lung systematically. I can see the right hemidiaphragm is a little bit elevated in comparison with the left side. And there is no any pulmonary lesion seen in the both lung fields. The heart shadow looks normal, no hilar lesions. The trachea is central. So I would like to go to the hidden, review hidden areas. There is some hyperdense lesion in the left lower neck, or it is in the upper part of the apex, maybe. I'm not sure about that. And I'm looking.
Can you point at that?
Yes, I will ask for a request.
Okay, it's
here.
Yeah.
Maybe some increased density here.
You just forget about that.
Yeah, okay, I will forget that. And no pleural effusion, no pneumothorax. I'm looking also behind a heart, retrocardiac, if there is any possibility. No, I can't see. So the bony structures looks unremarkable. I think there is some loss of the decrease in the volume of the right hemithorax in comparison with the left side. And the diaphragm is a little bit elevated. So for that, I may ask, I will ask for a CT just to know if there is any possible cause for increasing the yeah, the right hemidiaphragm is looks higher than normal. And
would you like to ask about anything?
Yeah. Well, I couldn't see any. Yeah, is there any CT for this patient? The soft tissue, maybe the soft tissue in the right side is a little bit wider, but I can't see any infection or, yeah, I can't see any soft tissue
Would you
lesions.
like to ask anything?
Is the patient had any operation or any, no. There may be a lesion here in the hilum.
Guys, can you mute yourself? Who is this?
Okay, I will give you a history of this patient.
Yeah, yes.
Late male with a history of trauma, an RTA.
Sorry, history of trauma?
Yeah, RTA.
Okay. So the ribs looks, yeah, there is some rib fracture in the right side, multiple rib fractures. The posterior ribs, let me count them, 1, 2, I think the middle rib fractures here, the lower rib. Can you see my marker, sir?
Yeah.
Yes,
Yeah.
I can
It's
see
fine.
incontinuity in the posterior ribs. If I count them, 5, 6, 7, I think these posterior ribs are fractured. So that's why, and there is soft tissue swelling in the adjacent soft tissue planes. So I would like to go further with the CT to know if there is any contusion or any problem in the underlying lung. There is
Which you cannot see on this plane film, right?
which I cannot see in this plane. Yeah.
Okay. Anything else on this plane film?
Soft tissue swelling, rib fractures, some
In your review areas?
yeah, I will go to the review areas. I can see there's some increased density in the apex of the right side, maybe apical cap, but no, the diaphragm, the mediastinum is also looks within normal. I couldn't see anything else.
Okay, can you check the right hemothorax again?
Okay, I'm looking to the neck. I can't see anything. I'm looking to the retrocardiac regions beneath the diaphragm and in the bones.
So the only abnormality you could pick is rib fractures.
Yeah. In rib
Anything
fractures,
relevant to that?
mostly there is associated pneumothorax, but I'm trying to see if there is any pneumothorax here. I am not sure. Maybe if I zoom a little bit, I can see if there is any pneumothorax, because there is a possibility of pneumothorax with these multiple rib fractures.
Okay, can you see my mouse?
No, I can't.
We
Yeah.
can.
So can you see my mouse now?
Yes, I can. Yeah.
So can you see this line?
No, I can't distinguish it. Okay, if it is there, then it is there. I can't.
Okay,
see
so
it.
this is the pleural line, and so this is a pneumothorax, looks like a moderate pneumothorax. So rib fractures. Okay, so
Okay.
let's go to the next case.
Thank you, sir. Hit on head in 50 years old male. Okay.
I'll give you the control.
I think I asked for control. Yeah. So this is a non-contrast CT scan of the head in a patient with a trauma history. I can see there is a linear hyperdensity in the interhemispheric line and also in the upper part of the, let me see, the left centrum semi-ovale intraparenchymally extended through the intraparenchyma and subdurally. So this is subdural and subarachnoid because it is also within the gyri. This gives me the impression of hemorrhage as the patient has a history of trauma. So there is a subdural and subarachnoidal hemorrhage. I would like to see the lateral ventricles. Yeah, there is no dilatation, and there is the ambient system and the CSF spaces looks not compressed, not effaced. In my routine practice, I go to the bone window also to see if there is any other fracture. So I will relay these findings immediately to the stroke team or surgical team on call to because this is subarachnoid hemorrhage and for further management.
Okay, let's go to the next case.
Of course, there was edema, also cerebral edema in the patient, but no effacement. Yeah. So this is babygram, including the abdomen and this chest in an immature, in a premature baby, because I can see the humeral head epiphysis. I can see there is increased opacification in the right upper lobe. However, it could be due to thymus, but there is it could be due to the thymus, but it is bigger than the size of the thymus. It could be also due to CPAM, but also the bowel loops looks dilated. And I would like to zoom it if there is any air in the bowel wall, just to exclude necrotizing intercolitis, because the bowel loops looks dilated, and no pleural effusion, no pneumothorax, no, the endotracheal tube looks in situ. So because of these dilated bowel loops and in a premature child, I would suspect of necrotizing enterocolitis, but I can't see any free air in the abdomen. Yeah. Okay.
Yeah, this is zoomed
Yeah,
view.
yeah. This is the zoomed image. So I can see there is air in the upper part of the esophagus. However, there is no air in the abdomen, in the stomach, but there is air in the bowel loops. Yeah. So the endotracheal tube. I want to see the end of the endotracheal tube. If there is any, I couldn't check it, but there is consolidation in the upper part of the right heart, of the right lung. So it gives me the evidence of congenital pulmonary airway malformation, CPAM. And
so what about the heart?
The heart is also, yeah, the heart is in the right side. It is on the right side, yeah, and not on the left. So there is dextrocardia. Yeah, that's why maybe there is also situs inversus, because I haven't seen the stomach on the left side.
What about the liver?
The liver is on the right.
So would it be situs inversus?
No, it doesn't.
Okay.
So this is possibly dextrocardia only, and I will relay these findings to the referred clinician to just look further. I will look to the other parts of the, because there is many associated syndromes in dextrocardia. Yeah, I can't see the radius here. Yeah, this is the ulna. There is no radius and the no thumb, only 4 fingers. So this is absent radius with dextrocardia. And yeah, this is a syndrome. I think, yeah, there is a syndrome here, a syndromatic thing. So I will relay these findings to the clinician just to go further with the situation.
This patient looks sick, right? You can see ECG monitors,
Yeah.
right?
Mm-hmm.
So do you see any NG tube here?
NG tube. I haven't seen the end of the NG tube. I think it is up, as if there is any esophageal atresia, because the air is just located in the upper part, and I can't see the end of the tube. That's why I have a suspicion of tracheoesophageal malformation or atresia.
How would you put it all together?
So this is all dysraphism or vectoral problems, because there is musculoskeletal problem and there is a cardiac problem. So this is vectoral. And
what would you advise next?
I would advise to look to the abdominal ultrasound, to look to the kidneys, and will examine the anal area for anal atresia or because these and may examine also the spinal canal, because there is a possibility of meningocele or vectoral.
Okay.
Yeah.
Let's go next.
Right jaw swelling in 45-year male. Okay, there is in this frontal X-ray of the mandible, I can see there is an expansile lytic lesion in the right mandible, which is well defined, and there is narrow zone of transition. It is surrounding the crown or the teeth, so it could be dentigerous cyst, and my differential, it could be ameloblastoma. However, this is very cystic and very lytic, and so
what's the
cyst,
classical appearance of ameloblastoma?
yeah, this it could be there is
Could be
cystic expansile lesion in the mandible. It is a possibility, yes. And I would like to see.
Sorry to interrupt, just to let you know that 15 minutes are up.
Okay. Yeah, there is expansile lytic lesion in the mandible. Yeah, it could be ameloblastoma, dentigerous cyst, or even brown tumor if the patient has a renal problems. I would like, yeah. Elevated lipase in 30 years male. So,
Dr. Sabahat, time is left. How much time is left?
has finished.
It's up, Dr.
Okay. Just can you go quickly through this?
Yeah, I can.
Sure.
The images focused on the, yeah, I can see there is the pancreas looks bulky, and there is some hypodense areas within the pancreas, and as the patient has high lipase also, it gives me the impression of pancreatitis. There is also some fluid collection around the pancreas, and
there is no fluid.
Sorry?
There is no fluid.
I thought some.
Have a look at this just quickly. Can you leave the mouse, please? Yeah.
Sorry?
Okay.
Can I?
Yeah, you can scroll now just quickly.
Okay, we'll go. I'm just going back, like it couldn't. Well, there is some. Yeah, there is some.
Do you think there is there any focal lesion in the pancreas, you think? Or?
Yeah, there is necrotic area in the body of the and in the tail. Necrotic areas in the
looks like a partial volume. Okay, just to complete the case. What phase is this?
This is diffusion weighted images.
Okay, so what's the abnormality?
I can see some diffusion restriction in the pancreas, and
do you need to confirm this? Do you see one phase, or you need to confirm it for another sequence?
Yes, of course.
Which sequence do you want?
ADC.
Okay. So is it true restriction or not?
Yeah, there is some. There is true restriction here in the area of the pancreas.
Yes, because of the time factor, let's. You did very well, Dr. Noran, actually.
There is pancreatitis.
So for feedback. So this is a first case here. So this is a straightforward case, but the without history, one may be misled with that. So when I give you the history, you quickly picked up the rib fractures. The pneumothorax, it's there, but it might need more windowing. But it's there. You see, this is the pleural line. If you can follow my arrow.
Yeah, you're right. Yeah.
So that's fine.
Thank you.
The next case, you did very well. Nothing to add. It's a trauma case, and I think. Yeah, so there is a subdural hematoma along the fox, and also when you see extension into the sulci, so you think of subarachnoid hemorrhage as well. So this patient has 2 bleeds. Should look for other areas of bleed, intraventricular. Should look for subdural hematoma. This is a case of trauma elsewhere along the tentorium as well. And also you say that you check the bone window, which is a good thing. Let's go to the next case. Yeah, this is a case of Bactrial. There is no history, a little bit misleading, babygram, you don't know what's going on. But yes, if you see the heart is on the right side, dextrocardia, there is a collapse, partial collapse of the right upper lobe as well. If you see, this is a coiled angitube that is found in an air-filled pouch, which is dilated esophagus, and still you can see gas within the abdomen. So there is esophageal atresia with tracheoesophageal fistula. The most common type is the third type. Also, once you get this, you should look for other abnormalities, association with bacterial, look at the vertebrae if there's any hemivertebrae or vertebral anomalies. And this patient, it was also shown on this film. I couldn't hide it, but it's the absent radius, and you added that absent thumb as well. So you should look for other associations of renal anomalies and cardiac anomalies as well. So well done.
Thank you. Good case. Very good.
You also did very well in this case. Describe this as an OPG, well-defined lytic lesion with smooth outlines, and you can see how it is related to the aneurysmatic tooth. I'm not sure if you mentioned this word.
Yeah,
buzzword.
Surrounding the crown of the aneurysmatic teeth here.
Yeah, so so this is most likely the indigenous cyst. Can put differential amyloblastoma unilocular, but it's less likely. The most common appearance, that is papillary appearance. And so also there is scalloping of the bone as well, benign looking lesion. I wanted to hide this history, but I forgot to do so. So
for my good luck, yeah.
Yeah. So the pancreas is it looks a little bit bulky. What's abnormal is the further appearance, and the clefts in this pancreas are not there. So it looks like smooth pancreas. You see, there is no necrosis. There is no peripancreatic fluid or fat stranding, and you have seen restriction of diffusion on MRI. So this is a feature of autoimmune pancreatitis. You don't usually see so this fluid is not peripancreatic. This is within the stomach or duodenum. So autoimmune pancreatitis, you might get a case like this.
Mm-hmm.
So
okay,
this is the last case, I think. Yeah.
Thank you.
So correction with the lab findings, the lipase, and it's part of IgG disease. You should look for other associations, okay, like rheumatoid arthritis and other associations. You did well, Dr. Nora. Good luck in your exam.
Thank you.
Okay.
Thank you.
I'm going to
Dr. Yousif.
Yeah.
Sorry, may I ask what are the findings on the MRI which you showed?
Yeah. So there is restriction of diffusion Yeah, let's have a look at it. Yeah. Yeah, this happens, it occurs in autoimmune pancreatitis. And spleen is also has restricted diffusion, but this is normal in spleen. Just
Okay.
I want to add this point for. Okay.
Okay, thank you.
Thank you.
Thank you, sir. Very good cases.
Thank you. Second candidate.
Dr. Nuran, can you take care of the timer now?
Yes, of course. I will.
Yes, Dr. Muhammad, how are you? I am Dr. Walid.
Hi, Sir Walid.
I'm fine, thank you. Dr. Mahmoud Al-Saidi is sending for you تحياته.
Oh, thank you. I've stopped sharing screen, I think. Can you see my screen now?
No, not yet. Yeah, I think now.
So first case.
Okay. Chest X-ray performed for cuff, 30 years, the female. This is frontal chest radiograph of skeletally mature female patient refilled. In the first look, there is no significant abnormality I could appreciate it, but I will take this film systematically. The lung apex bilaterally appear intact with no evidence of pneumothorax. Retroperitoneal shadows appear clear. Subdiaphragmatic areas appear also clear with no pneumoperitoneum. I think there is fine reticular shadows noted diffusely in both lung fields. So in patient with cough, I suspect element of cystic lung disease. I would correlate with previous available studies if present, and I would discuss with the clinician, and the possibility of CT chest will resolve this problem. The remainder of the examined chest skeleton appear intact. There is no obvious abnormality. So in conclusion, I am suspecting a cystic lung disease in this patient, and I recommend for CT chest.
Can you point with the arrow where you can see these cysts?
Just here, I request for remote control.
Okay.
What is obvious in this X-ray is just these reticulations, which is raising the possibility of presence of cysts with thin wall. But I am not appreciating a definite cyst here. I'm just suspecting.
The lungs are fine.
What? Sorry?
Lungs are fine.
So I am not appreciating a significant abnormality, and I would discuss with the clinician. And if the patient is still complaining, I will request for CT also. However, just a minute, sorry. There is decreased.
Can you control the mouse? Do you have the control?
Yeah, I just noticed something in the X-ray in the last minute. Okay, there is no problem. Here there is this is CT sagittal view with contrast revealed. There is area of contraction within the aorta noted just after the origin of the left subclavian artery. This is consistent with aortic coarctation.
Okay.
This is frontal radiograph of pelvis of skeletally immature patient, refilled. They examined the sacrum appear intact, left iliac bone also appear intact, right iliac. I just I am suspicious about the epiphysis of the right femur to be irregular in this area in comparison with the other side, and I think the thickness also small in comparison with the other side. So I am suspecting early changes of avascular necrosis on the right side. I would correlate with other views if available, and recommend for MRI for proper characterization. In this frog view, I think there is evidence of slippage on the right side. I'm not sure it is in the right side only or in the left side also. So in conclusion, this is SOFI, slipped upper femoral epiphysis on the right side. I would confirm my finding to the referring orthopedic for proper assessment with MRI.
What's the orthopedic management for that?
Mostly they make pinning for this this side and also for the other side, because bilaterality is higher in this situation.
Next case.
Acute headache, 45 female. So I
you have
was
the control?
Yeah, I think.
Okay.
I was provided with axial CT non-enhanced scan of 45 female complaining of acute headache. The prominent finding in this study is right frontal intraparenchymal hemorrhage, which appear extending to both lateral ventricles. There is associated surrounding parenchymal hemorrhage edema. There is evidence of slight mass effect on the overlying sulci if phased, and the underlying right lateral ventricle is also phased. No obvious midline shift. No other significant abnormality in the soft tissue window. In my routine practice, I would correlate with bone window to exclude the possibility of trauma. However, in conclusion, this is
There
a
is no
case
trauma?
Yeah, okay. So this is a case of intraparenchymal hemorrhage, which may be due to hypertension versus underlying space occupying lesion, which may be hemorrhage with extension of this hemorrhage intraventricularly. So I would advise for enhanced CT to exclude the possibility of space occupying lesion, or do enhanced MRI. I would confirm my findings urgently to the neurology team for starting the treatment.
Okay. You have the control,
Okay.
don't you?
This is post-contrast angiogram of the same patient, which revealed the multiple dilated vascular channels noted around this the previously mentioned site of hemorrhage in the right frontoparietal region. There is a draining vein noted extending to the vein of Galen, and I think the draining artery is coming from right middle cerebral artery. So in conclusion, this is a case of arteriovenous malformation. I would arrange with interventional radiologist for urgent coiling of this arteriovenous malformation as it is complicated by hemorrhage.
Okay, next case.
Testicular pain, 20 years male. This is ultrasound of the left
You
testicle.
can scroll, yeah.
Okay.
Okay.
Of the left testicle. I will take a look in the image first. Okay. The prominent finding in this study is intratesticular hypoechoic mass noted within the left testicle, which appear in this image, measuring about 1.1 centimeter. This mass is presenting high vascularity in Doppler study. There is associated punctate echogenic foci, which is consistent with testicular microlithiasis. So in patient like that, the first possibility is seminoma. Other differential will be less likely, like germ cell, other germ cell tumors and dermoid. But the first possibility is seminoma. I would convey my finding to the referring physician and arrange for staging CT, chest, abdomen, and pelvis, and discuss, refer the patient to urology MDT for discussion.
Why are you in favor of seminoma
What?
with the provided images?
I am worried about seminoma because the age of the patient and the presence of microlithiasis also. There is debate about that, but they found 50% of seminomatous patients have microlithiasis with that.
Okay.
No clinical history in this patient. I am provided with frontal chest radiograph of skeletally mature patient with no history revealed. The prominent finding in this study is left apical small, I think, small pneumothorax with evidence of pleural thickening at this area. The rest of the lung is presenting diffuse emphysematous changes with multiple I think reticulonodular infiltrations involving both lungs. Cardiac shadow appear slightly enlarged. Chest skeleton appear unremarkable. There is also area of right apical thickening, pleural thickening, which may be present in old age group. So in conclusion, there is diffuse reticulonodular infiltration involving both lungs with hyperinflation and suspected pneumothorax on the left apical region. I would convey my finding to the referring physician and recommend HRCT for further characterization.
Okay, we came to the end of the list.
Okay.
Dr. Walid.
The time
So I'm going to,
also.
No problem. Thank you, Dr. Muhamed.
okay. Just started from this case, and you mentioned that there is area of pleural thickening. I agree with that. but the most striking abnormality is this fuzzy pattern of it looks like bronchiectatic changes bilaterally, and even the heart contours are a little bit shaggy. The heart is not a lot, as mentioned. But there is one important thing that you forgot to check. So what do you think?
Sorry?
What do you think you have missed in this case? I kept telling myself, whenever I find a chest radiograph, I do look at the breast shadows. And
but I already looked. There is a breast shadow here, and there is another one here.
yeah,
I see two
the breast shadow.
shadows.
And can you see this?
It is coming under the mark, so I'm not
So what do you
appreciating.
think?
Dextrocardia.
So this is the hint. So this is the hint. Yes. So this is the left side.
But it's coming under the word X-ray, so I didn't take care of it.
That's with this
This is a mistake. I am always fall in this mistake. Right. You
so
are
this
right.
is situs inversus. So the diagnosis is
Cartagner syndrome.
Yeah.
I had the same mistake, Dr. Walid. Don't worry.
No, I am in rapid and in refuse Viva. I have this mistake always and always.
Yeah.
So in this case, yeah, you did very well. You have checked you described the lesion, which is hypoechoic and with increased vascularity. You mentioned the testicular microlithiasis. So Seminar, you gave a diagnosis, most likely diagnosis, and you gave a good management plan. You did well in all cases. Yeah.
No, I think it's the first case. I have a problem with it.
So you mentioned parenchymal hemorrhage. You say it's hypertensive hemorrhage. This is not a complication of hypertensive hemorrhage. It's a basic ganglia and the cerebral lumen. So bleed in unusual location, you should look for differential, and in young patients, you should put ADM in your differential diagnosis as well. Yeah. Right. Should also mention the extension of the blood into ventricles. You should look for any other areas of bleed, but it's fine.
Right.
In this case,
I get confused in this case.
Yeah, I couldn't remove this actually. So it's subtle, but it's on the frontal radiograph. There is widening of the growth plate here, and because the slippage is medial and posterior, so the frog leg would better evaluate this, and it's on the right side. The left is normal.
So I'm confused between Berses and Sufi here.
Yeah. So there is no parathes. The frog leg has removed your doubt. There is no sclerosis. The epiphysis height is normal.
I get confused in this case also.
Okay, sir, I have a question here. Are we going to advise pinning for both sides or only the affected side?
There is no problem in the left side.
Yeah.
So you just pin in situ or in situ on this. Yeah. Okay. This case, it's one of the normal cases. Apparently normal chest radiograph. So check your review areas. Don't forget this in your rapid reporting. Don't forget this in your Viva as well. So there is subtle here rib notching here, if you can, and if you check here the aortic arch, there appears to be some indentation.
This is what you chose the cases I always mistaken it. The aortic arcuation and the other one Cartagena. I always mistake with these cases.
Best wishes in your exam child. Okay.
This happens with everybody, Dr. Walid, don't worry.
Yeah.
Okay. It's fine. When you're on hospital,
you are not alone in it.
I hope not happen with us in the exam, inshallah.
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 Thank you, Dr. Muhammad. Thank you very much.
You're welcome.
Thank you, Dr. Muhammad. So I'll be going next now.
Yeah, I will keep
okay.
Yeah.
I'm going to stop sharing for 1 minute.
Yeah.
Can you see my screen now?
Yes, I can.
Okay, so this is your first case, Dr. Assad?
Okay, 35-year-old female with dyspnea and dizziness and fainting episode. So this is the frontal chest radiograph of 35-year-old female who has presented with fainting episode and dyspnea. On the first go, I can't see any obvious abnormality in the lungs. So I will go systematically. Looking at the lung apices, I don't see any evidence of any lung mass or consolidation, no pneumothorax. And behind the heart, retrocardiac area is clear. Hyla are normal. However, the right hilum is a bit prominent. I can see there is a possible nodule in the right lower lobe, which is
Hyla is
showing.
fine.
Sorry?
Hyla are fine.
Hyla are fine. Okay. Okay, I don't see any obvious abnormality below the diaphragm as well. So coming back to the bones. Okay, probably there is, I don't see the aortic arch on the left side. Or there is some opacity in the region of mid-thoracic level, which is showing some compression over the trachea, but the trachea is otherwise central. I don't see any significant narrowing of the tracheal margins. And I am unable to.
Excuse me, could you please just repeat what you have just said?
Sorry, in the right paratracheal region, I can see there is subtle widening of the right parastatical wide stripe. And can you, should I ask for the control?
Okay.
Okay, so can you see my marker?
Yeah, it's fine.
This area? That's fine.
Okay. So what do you think?
So I think it is some widening of the right parastatical stripe. It can be due to lymphadenopathy. It can be due to underlying lesion or mass. So to take it further, I need to have a CT chest with contrast for further evaluation.
So in summary, what have you said? In summary, Dr. Assad, can you hear me?
Yes, I can hear you.
Yeah, in summary. So in summary.
So sorry, to summarize, I can see the only finding is this right mild widening of the right parastatical stripe, which can be due to underlying mass, or it can be due to lymph node enlargement. So
yeah, you have the control, I think, don't you?
Okay, so this is the contrast enhanced CT of the chest for the same patient. So as I mentioned, there is right-sided aortic arch. and which was probably the cause of the opacity, which I was looking at in the chest X-ray. So, and this has some associations with underlying cardiogenic abnormalities like tetralogy of Fallot is the most common lesion associated with it, other than truncus arteriosus. So I need to, if the patient is not under cardiology workup already, I need to refer this patient to the cardiology team. And in the lungs, for the lungs, I need to have a look in the lung windows to see if I don't miss anything sinister in the lungs.
Okay. Do you remember the history of the patient?
So the patient has presented with history of syncope or one fainting episode. So the other thing I would like to look for is any possibility of AVM, but I don't see, I find any AVM or pulmonary avascular malformation on these images.
That's fine. That's fine. Let's go to the next case.
So 1-day-old respiratory distress newborn. Okay, so this is the frontal X-ray of newborn, 1-day-old. There are multiple lines and tubes I would like to comment. The endotracheal tube, I think, is properly sited. However, the NG tube is appearing coiled up within the left hemithorax, and there is a suggestion of possible diaphragmatic hernia with stomach bubble, which is present in the left thoracic cavity as well. So it needs to be communicated to the referring team, and I think there are some rest of the tubes are umbilical venous catheter and umbilical arterial catheter are properly sited. And there is some.
What's your diagnosis?
Sorry?
What's your diagnosis?
So I think since due to the position of the NG tube, my suspicion is this could be a diaphragmatic hernia, because I don't see really, the stomach bubble is also present within the left-sided thoracic cavity. So need to compare with the previous ultrasound appearances of this child, if it has already been reported, or otherwise it needs to communicate to the pediatric surgical team for further management.
Okay, let's go next.
Left flank pain, 30-year-old male.
You have the control, yeah?
Yeah, okay. So this is the CT abdomen and pelvis with contrast images, 30-year-old male who has presented with left flank pain. I would have a look at the images first. Okay. So the stacking abnormality is in the region of the left para-aortic region, or in the left retroperitoneum. There is a lobulated soft tissue density lesion, which is compressing over the left renal hilum with subsequent left-sided hydronephrosis and hydroureter. And I can see it is causing some displacement of the vessels. And the rest of the images, I don't see anything other than, okay. So I think there is a possible testicular mass as well on this image, especially in the left side. So combining all these findings together, this is possibly a retroperitoneal lymphadenopathy related to left testicular mass, which is with resultant left-sided hydronephrosis, and it needs urgent communication to the referring team, especially urology, for possible drainage of this hydronephrosis and nephrostomy. And subsequently, it needs to be referred to urology for further management, including chest, CT chest, and MDT discussion.
Okay, let's go next.
"60-year-old female, no neurological complaints, rule out vertebral fracture after trauma." Okay, so these are the sagittal views of 60-year-old female. Need to rule out possible fracture after trauma. The striking abnormality I can see is an evidence of possible segmentation anomalies in the mid and lower thoracic level. There is a vertebral body hemangioma as well. However, I don't see any evidence of acute fracture on these images, but I would like to confirm on frontal coronal plane images as well. And there, I think there is a bony bridge present between the facet joint, which is extending from the superior margin of, I need to count this, probably T11, and which is in continuity with the posterior elements of proximal thoracic vertebra. With presence of bony bridge, I need to rule out any underlying spinal canal abnormalities like diastematomyelia. So I would suggest further evaluation with MRI of the thoracolumbar spine for this lady.
Would you like to review other sequences or reconstructions? Yeah.
Okay. Okay, so on the coronal views, these show evidence of butterfly vertebra on D11. There are multiple hemangiomas within the T10 and possibly L1. Can you have a look on the axial? So I believe on looking at the axial views, I believe this is some neural canal defect. Yeah, there is some widening of the neural and absent neural canal on the left side at this level, and there is some defect in the level of the posterior element as well. So I'm not sure what actually the abnormality is, but I need to discuss the finding with the with my neuroradiologist, for further confirmation of the findings, and then we can convey the finding to the referring clinician accordingly for further management.
So what do you think this patient condition is part of which category?
Frankly, I'm not really sure what actually, part or what actually the abnormality we are dealing with, but I think there is some abnormality within the spinal canal, and it needs to be discussed with the clinician, and I will discuss the finding with my neuroradiologist colleague as well.
Okay, let's go to the next case.
Time is over.
Okay, just go through this case quickly. Have you seen the history?
Yeah, altered conscious state, 70-year-old male. So I'm presented with a CT brain axial non-contrast images of 70-year-old male patient who has presented with altered state of consciousness. I'm just trying to scroll through the images to look for if I find anything obvious. Okay, in the first scroll, I can see there is evidence of left hyperdense MCA sign on the left side. And there is evidence of some, I think, insular ribbon sign as well, loss of normal insular ribbon in the left side. So there is some hypodensity. So I believe it is a case of left-sided MCA infarct. So I don't see any evidence of intracranial bleed, no midline shift, or no ventriculomegaly. And I would like to have a look on the bone windows to see any fractures. To conclude my findings, this is a case of left MCA infarct, which needs to be communicated to the stroke team urgently. And I can see there is possibly a low attenuation within the medulla as well, if this is not something which is due to partial volume.
Yeah, it's not. Okay.
Okay. So, so further evaluation with CT, angiogram, and then subsequently discussion with the neurosurgical team and neurology review.
Okay, thank you, Dr. Asad, for.
Yes, thank you.
I'm going to give feedback. Actually, you have picked up all cases. Starting from this case, nothing to add. It's a hyperdense left MCA with low attenuation involving the left insula as well as the basal ganglia, which is the distribution of the MCA. You get all the signs of the insular ribbon sign and the basal ganglia obscuration. So it's an emergency and should immediately communicate the findings, as you mentioned, to the stroke team and recommend CT angiography for further evaluation and management. That's fine. And this case, yeah, you've picked everything. Maybe on the sagittal it's not that clear, but on the axial, if you check it, yeah, it's in the bone window. You see a septum that's
yeah, it's a bony septum.
The bony septum, yeah. So as you mentioned, you gave that thing, I think, from the sagittal, like the diastematomyelia, and this is a part of a spinal dysraphism. You need to look for other abnormalities like spinal cord tethering, the spinal cord lipomas, and other associations. Spinal bifida as well. But this patient is asymptomatic. There's nothing. This patient is just incidental finding.
Okay.
Yeah. And this case, I'm really very happy that you scroll down to the end of the film, which is the clue for the diagnosis of this case.
Yeah, yeah.
I gave a case of seminoma, the previous candidate, but I like this case because just to insist that scroll throughout all images.
Yes,
Because
definitely.
if you don't scroll to the end, so differential for this would be lymphoma. It's fine.
Lymphoma,
It's
yeah,
differential,
yeah.
is there's encasement of the vessels and soft tissue. There is no compression. So differential would also in this young age could be metastasis like of seminoma. And this is the clue of that case. So very well done. This case of chest and abdominal radiograph of this neonatal baby. The first thing that you have to comment upon are the lines and tubes. The ET, you comment about the ET tube is fine, and the angio tube is not going, it's going to the stomach, but its abnormal position at the end or the tip of the tube is located within the left hemithorax. That is a clue for there's something wrong with the stomach side. So this is most likely a congenital diaphragmatic hernia. It's a more common type, spugdalic on the left side, and in young infants with babies. So this appears to be like missed spugdalic hernia. The thing that you missed, that this is the venous, the arterial catheter is appropriately sited. The left, the venous catheter is malpositioned. It's within the left portal vein.
Okay.
So the liver is also herniating. It's giving a clue about that. So it's not a normal direction. Yeah. So otherwise you did fine.
So I thought there is something there, but I I did not mention it because I was not sure.
Before you, so as not to forget the lines and tubes first.
Yeah, thank you.
In this case, you've also picked it. It's almost apparently normal chest radiograph. But the abnormality is that you see the aortic arch it looks very small. It's not the normal configuration of the aortic arch, and requested CT scan. That's fine. And if you remember the history of the patient, that 35 female with dyspnea, dizziness with one fainting episode. The history is important, but it's not always explained by the CT or imaging findings. But the abnormality, as you see, you said this is a right aortic arch is apparent, and you see here the trachea is a bit compressed. It's not a complete ring, vascular ring, but you see the left brachiocephalic artery along with the right arch are compressing a bit on the trachea.
Okay.
Otherwise, it's fine.
Okay, thank you.
So
nice cases, Dr. Yousif. Thank you so much.
Thank you. Thank you very much. I'm going to stop sharing.
Yeah, now Dr. Rafiq, Muhamed Salman Rafiq, I think he's joined us now.
Okay.
Hello.
Yeah, hi.
Yeah.
Can you see my screen now?
Yes, I can.
It's your first case.
So, this is a chest radiograph, a frontal projection of an adult patient that shows a normal appearing lungs. I cannot see any obvious pneumothorax. The cardiomediastinal contours, retrocardiac regions are fine. The CP angles are clear. The area below the diaphragm is also unremarkable. The shoulder girdles show no obvious abnormality. Looking at the bones, They also grossly appear unremarkable. The left breast shadow is absent, and I can see multiple surgical staples in the left axilla, suggesting that the patient might have had a mastectomy for a breast and accompanied with axillary dissection. Now looking at the bones more closely, I'm looking for any metastatic lesions or any pulmonary nodules, which I have not been able to find so far. The bones, they grossly appear unremarkable. So to conclude, absent left breast shadow with axillary surgical clips. So I would compare these findings with previous imaging if available on the PACS, and compare with them. I would inform the referring clinician about the findings, and the case would also inquire about the history, that why this radiograph was done. And if there is strong suspicion of a pulmonary or osseous metastasis, this patient should proceed with a post-contrast CT chest and bone scan.
Okay, let's go next.
So do I have the control?
Yeah.
Or
can you see the history?
Yeah, I can see the history. Yeah.
Okay. So just focalize it.
Do I have the control?
Yeah. Just can you read the history, please?
I've read the history. Yes.
Okay.
Should I ask for the remote? Should I ask for the control?
Dr. Sal. Yeah. Okay.
I've requested. Yeah.
Okay.
So I'm just trying to scroll. Yes, I think I can. So this is a CT abdomen pelvis of a 40-year-old female who has presented with lower abdominal pain. So I'll give it a quick look, starting from cranial to caudal, and keep on describing the findings. So the first thing that I've noted is that the liver is somewhat centrally placed within the abdomen. The spleen is on the right side. In fact, there are many splenials. So this appears to be a situs inversus, and with possibly a polysplenia. The stomach is also on the right side. I'm trying to look at any hepatic lesion, which I have not found. And going on further caudally, the kidneys, they are unremarkable. And scrolling out further down, I can see a fluid-filled structure that is tubular, and it appears to be arising from the large bowel, and it is I'm going to trace it and confirm if it is blind ending. Yes, it is blind ending. So a fluid-filled structure arising from the large bowel, blind ending, thick-walled, enhancing walls with perilesional fat stranding, and I can also see a couple of calcifications at its base. So this likely represents a case of acute appendicitis with appendicolits. And I will immediately pick up the phone and inform the findings to the emergency physician, and inquire about the total leukocyte count as well. The general surgery on-call team has to be informed as well. And this is a surgical emergency, and it has to be managed accordingly.
Okay, so this patient has two conditions, which one is acute and other is not. What do you think about the other findings you mentioned regarding the liver, the spleen?
Yes, so I'll go back again to those findings. So the patient does appear to have levocardia, and the liver, I'll have a closer look again. It does appear to be a case of situs inversus, and
It is or not?
It is situs inversus. as the stomach is on the right side, and
the heart is on the left side.
And the heart is on the left side. So a case of levocardia with the situs inversus means that we would expect the patient to have cardiac anomalies.
Do you think the liver is okay?
Yeah.
Okay.
You were asking something?
Yeah. What do you think about the liver? It looks left-sided. Or
so the liver. It is more in the midline, and it's hard to me to figure out if it is it appears to be left-sided. It appears to be left-sided because the left lobe appears to be on the right side and the right
so what
on
do
the
you
left.
think?
So I think this is a situs inversus with levocardia. Sorry. Sorry, I couldn't hear you.
So you say situs inversus with acute appendicitis?
Yes.
Okay. So can you just leave the mouse, please?
Yeah.
Okay. Let's go to the next case.
Should I start seeing the images?
Yeah, just vocalize the history for others just to be.
Yes, it's a case of a male, a 2-day term infant who has failed to pass meconium and has presented with abdominal distension. So abdominal radiograph frontal projection of a 2-day term neonate with failure to pass meconium. I cannot see any gas in the rectum to begin with, and the small bowel loops are dilated. They do not conform to the normal mosaic appearance as should be seen in this age group. And there is no gas in the rectum. I can see the NG tube in place with its tip in the fundus of the stomach and is normally positioned. Looking at the rest of the imaging, the bones and there are no segmentation anomalies, and the rest of the bones and soft tissues are grossly unremarkable. The sacrum, I cannot appreciate that very clearly, but it appears to be somewhat smaller. And so in conclusion, I would give a differential of a few entities in a child who has failed to pass meconium: anal atresia, imperforate anus to top, and then are other entities like Hirschsprung disease, ileal atresia, and meconium plug syndrome. So I would discuss these findings with the referring clinician, and I would advise a barium enema, beg your pardon, a contrast enema study to further delineate the differential that might be preceded with an invertogram to see if there's an imperforate anus.
The control is yours.
Right. So these are fluoroscopy images of contrast enema study of the same patient. So I'm trying to scroll. So starting from the first image, the large bubble appears to be a microcolon, which is an appearance of an unused colon. And I cannot see the contrast going into the ascending colon from the transverse colon. I'm going to see the prone images now, and we'll try to scroll through them and see if the contrast has passed further. I cannot see the contrast passing beyond the transverse colon into the ascending colon. On the previous images, I can see a few filling defects, which are likely meconium plugs in this patient. So my differential in this case would include a long segment Hirschsprung disease and meconium plug syndrome. And I will convey these findings to the referring clinician and the pediatric surgeon to further manage
Okay, let's go next.
Should I start? So this is a radiograph of abdomen, a frontal projection of a skeletally mature adult patient. And in this radiograph, I can see widespread calcifications in the abdomen, and these appear to be infiltrating the peritoneum regarding their distribution. Further, I can also see some surgical staples in the bilateral lower quadrants, which are more numerous in the left lower quadrant. Looking at the rest of the abdomen, I cannot see any obvious pneumoperitoneum. A few gas shadows appear to be confined within the bowel. There is a radiopaque focus in the right upper quadrant that can be a gallstone. And there is a bowel loop in the left upper quadrant, which I cannot make out whether it is small or large bowel. Looking at the bones, I cannot see any obvious pedicular lesion, no obvious metastatic, any lytic or sclerotic lesion or any fracture. So to conclude, the patient has had a surgery for some disease entity in the left lower quadrant, and there is widespread peritoneal calcification. So I am thinking about in an adult patient, peritoneal deposits from a metastatic carcinoma that is calcifying. And other than that, it can be, the appearance can also be seen in TB. But I would be more concerned with a peritoneal carcinomatosis from a mucinous tumor or a ruptured mucocele of appendix, or a ruptured mucinous tumor resulting in peritoneal infiltration. So I would convey the findings to the referring physician, would ask them to arrange for a CT scan to further delineate the cause. And would also ask about the history, about the pertinent history about the surgery that the patient has had.
Okay, so this is your last case.
So this is okay. So this is a radiograph of tibia fibula, a frontal projection, and in this I can see a clear overlap of the femoral condyles over the tibial condyles. The fibula is also somewhat cranially oriented as compared to what it should be normally. And in my routine clinical practice, I would have looked at orthogonal views to see if there's any dislocation. I'm suspecting an anterior or posterior dislocation at the knee joint. So the horizontal beam view confirms the findings of an anterior dislocation at the right knee joint. The tibia and fibula are anteriorly displaced with respect to the femoral condyles. I will immediately inform these findings to the referring physician and the orthopedic surgeon on call. And they should immediately reduce this dislocation, and the patient should be managed urgently.
What complications would you expect with this condition?
I would also expect neurovascular complications, and in particular popliteal artery occlusion. I will also inquire the referring physician if the pulses in the distal right lower limb are normal, and if they are not, a further evaluation with a CT angiogram may also be considered.
Okay, so we came to the end of the list, and you did really very well in all cases. Just a message from this case: it's a simple case, but You see overlap here, and whenever you find skeletal X-ray, always ask for other orthogonal view. This is the message. It's just shown here. I couldn't hide it also, but it's fine. This case, yeah, it's a story film, as Dr. Khan says. So we can see sheet-like of calcification spread throughout the abdomen. So this most likely peritoneal calcification, and you can see clips also on the left pelvis. This indicates a previous surgical intervention. This actually is a patient with peritoneal dialysis for many years, and this surgery is transplant surgery. So it's a case of differential, for peritoneal calcification. In this case, specifically, it was diagnosis was of encapsulating peritoneal sclerosis due to long-term peritoneal dialysis may lead to sometimes subacute small bowel obstruction or bowel obstruction, because of the sclerosis. Other differentials also could be due to pseudomyxoma, peritoneal, and as you mentioned, other ovarian cancers, and so metastasis, peritoneal carcinomatosis, tuberculosis. It's a case of discussion.
Yeah.
This case, yeah, it's good that you commented about the dilatation of the bowel loops. I should comment, I'm not sure if you mentioned there is no free air or not, or pneumatosis. It's good that you mentioned there is no air in the rectum. And you recommended the next step, which is enema. Just one thing I have to add, whenever you find fluoroscopic images or study, just try to scroll. Don't think it's a static image, just always scroll, okay? You may think and judge upon one image, which you may not reach the diagnosis. Just always, whenever you find a fluoroscopic study, just scroll. As you mentioned, yeah, the contrast has, from the start, yeah, it classified the rectum, then the colon. The colon, as you mentioned, is small microcolon, and the contrast has stopped at one point. Even with change position with time, is still there. So differential for this would be meconium alias and ilia atresia. So well done. And this case with 40-year-old with lower abdominal pain. So there is an acute pathology, which is acute appendicitis, which you picked up very well. And there is an incidental finding. So the message from this case is, whenever you find an abnormality, just keep looking for other abnormalities for lung cases and Viva as well. And this case, the liver, you said it's on the left side, but actually it's not left side. Here it looks on the right side, and here it looks on the left side. So it's like central liver or ambiguous liver. The stomach is the right side. There are multiple splenoles, it's polysplenia, and you see the IVC, the azygous continuation of the IVC. There is no intrahepatic segment, okay? And so the diagnosis, the cold diagnosis, it's not a hot diagnosis, is heterotaxy with left isomerism. Also, you can find heterotaxy, yeah. Okay, and also polysplenia syndrome. Also, you have also asplenia syndrome, and this is the polysplenia syndrome. We may also find bilateral bilobe lengths, and so it's fine. You picked all the findings. This is just an observational case. From the start, if you notice, there is no evidence, there is increased lucency of the left hemithorax. It's not that much, but the mastectomy. So this is what I've been saying to myself whenever I find a chest radiograph, always look at the breast shadow and look for coarctation of the aorta and the mark as well. So when you find the radiograph is apparently normal, just don't forget these things. You picked up the spherical eclipse indicating the axillary clearance and left mastectomy. There is nothing abnormal in this case, but you should keep looking at the bones for any metastasis, carotid metastasis of the breast. So that's all. You all did very well, and best wishes for your exam. I hope.
Thank you. Thanks a lot.
I think cases are from this side. I thought the cases are not difficult cases, but just because of the hot seat, you may forget to check something like that. But you all did very well. Thank you very much.
Thank you
Thanks
very
a
much,
lot.
Dr.
Thank you, Dr. Yousif.
Yousif. They were great cases, and you are a very gentle and a patient teacher. So I think we all thoroughly enjoyed the session, and thank you very much to all the attendees, and very well done all the volunteers. So if nobody has anything to add, we can end the meeting. Thank you, everyone. Thank you, Dr. Yousif. Okay, bye-bye.